Good morning, everybody. I am excited to co-chair this session with Becky. I wanted to make a couple opening remarks, and then Becky will introduce our speakers. So, this issue of access and inclusion has been a perplexing and challenging one for my entire professional career. In 1993, in the NIH Revitalization Act, there was a requirement that NIH ask its investigators to include women and racial and ethnic minorities in clinical research. During my time at NIH, which was extensive, there were a number of opportunities to look at how effective those policies were and to make amendments to the implementation, essentially, of the rules requiring inclusion in clinical trials. There's also the whole set of related issues around preclinical research that we're not going to talk about today, obviously. So how are we doing? I'm generally an optimistic person, but on this point, I think there's plenty of reason to be pretty deeply distressed. And I'll share a couple of statistics with you. So as we're talking today about virtual clinical trials, I think it's important to think clearly about whether or not we can have optimism around how virtual clinical trials might help us address these problems of inclusion and diversity and equity and access. And what we might want to do in terms of data collection at the beginning to really monitor whether or not we are helping solve the problem or actually exacerbating the problem. So the sort of depressing statistics I want to share with you are from a paper by Stacy Geller this year, in which she did a systematic review of clinical trials that were published and supported with NIH dollars. And she basically has repeated this assessment periodically since the 1993 law was placed. So 25 years ago, the problem was recognized, and here we are 25 years later. How are we doing? So in 2004, 67% of papers did not include sex in the analysis, nor include an explanation of why sex was not included in the analysis. 67%. How are we doing in 2015? In 2015, 72% of NIH-funded clinical trials did not include sex in the analysis nor provide an explanation of why not. And she excluded from her systematic review papers that were focused on prostate cancer, for example. How about with racial and ethnic minorities? So in 2004, 83% of NIH-funded studies that were published did not include race or ethnicity in the analysis, nor an explanation of why. And how are we doing in 2015? 85% of papers do not include race and ethnicity in the statistical analysis, nor do they include an explanation of why not. So there was some attempts and new policies actually coming out this year about requirements in the design that you appropriately include at least women in the design so that you can have sufficient statistical power to be able to do an analysis, unless there's a strong scientific reason of why not. But here we are 25 years later, and we really haven't made much improvement. So I think we should keep that sort of squarely in mind as we are thinking about new opportunities, because frequently we think, this new approach or this new method is going to be the solution to this problem, and yet we really haven't cracked this nut. And so with that sort of depressing wet blanket introduction, I will turn it over to Becky.
Thank you, Kathy, for those unfortunate statistics. Before I introduce our panel, I just want to share some of my frustrations on a very tiny virtual trial I'm running. I work closely with the bone marrow transplant unit at Children's Healthcare of Atlanta, and we have discovered in our studies that the siblings of children who are having transplants are totally isolated because they're left at home when the parents are with the very, very ill child. So we're trying a virtual trial of a child life specialist interacting by FaceTime or Skype with the children in rural Georgia who can't get up to the hospital. And it's working beautifully except for connection problems. So the child life specialists will be having this wonderful, intimate conversation. They're sharing about, how lonely they are, or the problem with chores, or the fact that they never get to see mom or dad, and then it goes blank, and the child life specialist can't respond, and she is so frustrated. We gave the child iPads, so we prepared that, but we haven't figured out how to fix the connection problems. So now that we've given this really depressing beginning, I would like to introduce our panel, who hopefully will give us hope on the way we can move forward. And if the panel would like to come forward as I introduce you. First of all, we have Will McIntyre, who's going to be our patient advocate on the panel this morning. Sally Oken, who is for Patients Like Me. Silas Buchanan, who's for the Institute for E-Health Equity. And Shireen El-Tuki, who is at the National Institutes of Minority Health and Health Disparities. And as you all know, there's complete bios in your packets. And we will just proceed with Will, if you will head us off.